All right. We made it to a non-stress test, okay? Now, with a non-stress test, you want to see 2 or more acceleration of 15 beats per minute or more with fetal movement. So underline fetal movement, okay? You will also see that we've put a little definition of acceleration that you can read later, okay? Now, each increase should last for 15 seconds, and this is recorded for 20 minutes. Recorded for 20 minutes. Now, do you want this test to be reactive or non-reactive? Reactive, because what does reactive mean? Reactive means accelerations are present. Accelerations are present. So that's a good thing. Now I want you to think about this. If I sit down and rest, what is my heart rate naturally going to do? Slow down. If I get up and run out of the room, what is my heart rate going to do? It should go up. So I'm going to ask you a question. Do I have variability in my heart rate? Yes, I have variability. Do I have accelerations? Yes, I have accelerations. So variability in accelerations would be good things. If I have it, don't we want the baby to have it too? Yes, we want the baby to have those things. Now here's something else. If you have a baby who with simple fetal movement cannot get their heart rate up to 15 or sustain it there for a period of time, is that baby going to be able to handle labor and delivery? No, they are not going to be able to handle labor and delivery. Now tell the person sitting next to you how you get your patient ready for a non-stress test. What do you teach them to do? Okay, all you do is put them on a monitor, right? And you tell them that every time they feel the baby move, they need to do what? Punch the button. Punch the button. And what you're doing is looking at the fetal heart monitor and making sure that with simple fetal movement, there is an increase in acceleration in the baby's heart rate. Now, let's look at the contraction stress test, okay? Contraction stress test. Oxytocin challenge test is sometimes another name for it. Now, this is only performed on high-risk pregnancies, okay? Like preeclampsia, maternal diabetes, any condition where we suspect any form of placental insufficiency, okay? So it's only done on high-risk pregnancies, and this determines if the baby can handle the stress of a what? Uterine contraction. A uterine contraction. You see, uterine contractions decrease blood flow to the uterus and the placenta. And if the decrease in blood flow is great enough to cause hypoxia in the fetus, the fetal heart rate will decrease from your baseline fetal heart rate. That's a deceleration. And we do not want to see what on the fetal monitor? Late decelerations, because this means uteroplacental insufficiency, which basically means your placenta's wearing out, okay? In simple terms, do you want a positive or a negative test? Negative, because what does negative mean? No late decels. No late decels. Now take about 10 seconds and read that little box to yourself, please. Okay, let's move on. This test is rarely performed before how many weeks? 28 weeks is what I want you to write down. 28 weeks. Now, I bet your teachers in school said a bigger number than that, like in the later into the pregnancy. And yes, the later into the pregnancy, the better for this test. But you got to remember something. We just got through saying that this is only done for high-risk pregnancies. So it may have to be done earlier, but I would never want to do it prior to 28 weeks because are we inducing a contraction on a pregnant lady here? Yes, and when you induce a contraction on a pregnant lady, what might you get at the end of the contraction? A baby, right? That's right, a premature baby. So that's why you would not want to do it prior to 28 weeks. Now, one more point I want to make about this test is this. The results are only good for 1 week. The results are only good for 1 week. So let's say I've got a high-risk pregnancy. Maybe I'm pregnant with triplets, all right? And this week I go in and they do the test and there were no late D cells. So what are they going to tell me to do? Go home and come back in 1 week. Well, I go back the next week and they see late D cells. What are they going to do then? That's when they're going to make me go ahead and deliver or C-section or whatever, okay? Because the baby's going bad at that point. Late D cells are bad. There are other kind of D cells out in the world that aren't any big deal, but the late D cells are really, really, really bad, okay? Now, true labor. With true labor, do we have regular or irregular contractions? Regular. Do the contractions increase or decrease in frequency and duration? They increase. And the discomfort is in the back and it radiates all the way around to the abdomen. And what happens to the pain level with the change in activity? It increases. It increases. Now, false labor. With false labor, the contractions are irregular. Irregular. And where is the discomfort mainly? Abdomen. Mainly just right in the front here. And what happens to the pain with a change in activity? It decreases or goes away. It decreases or goes away. Now that's probably a Braxton Hicks, okay? That's probably a Braxton Hicks contraction. If somebody's having a Braxton Hicks contraction, they can do just about anything different, like roll over in bed, walk, drink a glass of water, and if it's a Braxton Hicks, it'll probably go away. All right, the next thing we have is epidural anesthesia. Now, I know that ladies in labor can receive a lot of different types of pain meds, okay? But we're going to focus on the epidural. Now, we've listed for your viewing pleasure a chart with different types of pain meds, okay? But let's go back to the epidural for a second. One position that the patient can get into for this procedure is to lie on their left side, legs flexed, but the back is not as arched as with the lumbar puncture, okay? Now, I know what you're thinking. You're thinking about what you saw in clinical, where they really, really, really arch the back. Well, that's in the hospital. On NCLEX, we're not going to arch the back a whole lot, because the more you arch the back, the greater the chance they're going to get into the spinal fluid, and that's what we don't want to happen, okay? Now, I know there are other positions they can put the patient into, such as they may just prop them up over the bedside table with their head down on the bedside table, okay? Or they may say, hey, just scrunch up your back like a cat. And then sometimes they're even told to sit Indian style. Now, that's a weird one, isn't it? You don't see that done a whole lot. Now, you tell a pregnant lady to get Indian style, and what's she going to say? How, right? Well, they're going to put you in that position if that's the position that particular doctor or anesthetist likes, okay? Now, it is given in stage 1 at 3 to 4 centimeters dilation. And I want you to put a star by the next two things. You'll see why in just a second. Usually there's no headache because they did not get into the spinal fluid. Did not get into the spinal fluid. Now, what is the major complication of an epidural? Now, don't get me wrong. I know there are lots of things that can happen, but the most common complication is hypotension. Hypotension. Blood pressure bottoms out. So, of course, we're going to be monitoring the blood pressure. Now, be aware that a lot of people in the hospital these days get epidurals, not just pregnant ladies, okay? Now, one of the ways that we fight hypotension is with IV fluids. That's why we put a star by that. We're going to bolus the patient with 1,000 cc's of normal saline or LR. Okay? Bolus them with normal saline or LR to keep that blood pressure up. We're going to build up the volume. Or you can change their position too. Okay? Change their position. Sometimes that will help get their blood pressure up. Now, we put the patient in semi-Fowler's position and on their side to prevent vena cava compression, which will decrease venous return, decrease cardiac output and blood pressure, and also decrease placental perfusion. And the patient's position will need to be changed from side to side hourly. Now then, let's look at the patient receiving oxytocin, Pitocin. First of all, they need one-on-one care. Now, I know that's not what you've seen at the hospital, okay? But we're talking about a different scenario here. They want you to stay with the patient the entire time they're receiving the Pitocin, because aren't there a lot of bad complications that can occur? Yes, there are a lot of things that can occur. They want a brand new nurse to stay with them. And the bad things that can happen are things like hypertonic labor. Hey, that's just a contraction that doesn't stop, right? It's a contraction that doesn't stop. Well, not only can the mother not handle this, but who is it going to kill? The baby. Because the only time the baby gets blood and oxygen is between contractions. Between contractions. That's why we always want to pause in between contractions, okay? Also, other bad things that can happen: fetal distress, uterine rupture. Now, let's talk about that for a little bit. Now, with uterine rupture, it may be complete or incomplete, all right? Complete uterine rupture is when the tear goes through the uterine wall into the peritoneal cavity. Signs and symptoms: sudden, sharp, shooting pain, like the patient may say something gave way. And if in labor, the contractions may stop. That's always an emergency sign or a red flag. If anytime the contractions suddenly cease, you should think uterine rupture. And when the contractions stop, their pain will be relieved. And we get signs and symptoms of hypovolemic shock due to the hemorrhage. And if the placenta separates, the fetal heart tones will be absent. You see, their uterus is filling up with blood now. Now, an incomplete is through the uterine wall, but stops in the peritoneum, but it doesn't go all the way into the peritoneal cavity, all right? So you're not necessarily leaking completely out. Now, signs and symptoms: internal bleeding, pain may not be present, the fetus may or may not have late D cells, the patient may vomit, faint, have hypotonic uterine contractions, or lack of progress. Fetal heart tones may be lost, okay? Now, listen to me for a second. The uterus may rupture due to a rupture of the scar from a previous C-section. You see where it says VBAC? Vaginal birth after C-section? Well, these are the people that are highest risk for uterine rupture, okay? Because the scar from that prior surgery can rupture. It's a weakened area there. Also, uterine surgery or trauma, malpresentation of the baby during delivery, or a difficult forceps delivery, because you know that forceps deliveries can be very traumatic. You don't see a lot of those done anymore. Now, we want a contraction rate of 1 every 2 to 3 minutes, with each lasting 60 seconds. Now, do we want to pause in between contractions? Yes, we've got to have a pause in between contractions, because we said that's when the baby's going to get oxygen. It's between contractions. Now, we're going to discontinue it when the contractions are too often, when the contractions are lasting too long, or any sign of fetal distress. Now remember, oxytocin is piggybacked into the main IV fluid. So when you discontinue the oxytocin, make sure you do not turn off your main IV fluid. Now, what position should the patient receiving oxytocin be placed? Any position except flat on their back. Any position except flat on their back. Supine is contraindicated in all pregnant women, okay? Because that causes too much pressure on the vena cava again. Now, if the patient has any unreassuring fetal heart tones like fetal bradycardia, then we're going to put the patient on their left side to enhance uterine perfusion. So if you've got somebody who's not having any trouble, the baby's doing good, any position is fine except flat of their back. When people start having trouble, like with the baby, like the fetal heart rate changes in some way, that's when you put them on their left side to enhance uterine perfusion. Now, what should be done with the infusion if late D cells occur? Turn it off. Turn it off. And hurry up and go get somebody that knows more than you is the plan. All right. Now we're to an emergency delivery. Now, when I say emergency delivery, I don't mean in the hospital. I mean way out in the woods somewhere where we don't have any help. We don't have anything. Okay? All right. So it'll be a little bit different. No supplies here. Now, does anybody know who I'm talking about if I say Bo and Hope? Does anybody know who Bo and Hope are? Days of Our Lives, that's right. And even if you don't watch Days of Our Lives, you might be able to relate to this story because you've probably just seen the commercials, okay? So let's pretend that Bo and Hope are together and they're about to have a baby, and it's Bo's baby, okay? And it's Christmas time, and they go to their ski lodge in Utah, which they own, right? And it's just them and the butler. And when they get there, the ski lodge is decorated with all these beautiful Christmas trees, like 15 different Christmas trees, and each tree is decorated with a different theme for every year that they've been together, right? And it's just beautiful, and thousands of candles are lit everywhere. Well, it starts snowing, okay? A blizzard's going to hit. They need more candles. Even though we have 1,000, we send the butler out for more candles. So it's just Bo and Hope there with the fire going, right? Right. Well, what's going to happen to Hope? She goes into labor. Well, who's going to deliver the baby? Bo, because he can do anything, can't he? Yes, Bo can do anything. So the first thing he does is puts her to bed. And I like to envision a big 4-poster canopy bed here, okay? With lots of big fluffy Laura Ashley pillows behind Hope, and she's looking so pretty, isn't she? Yes, no swelling, no nothing. Looks just like she did before she got pregnant. And then he washes his hands and he puts something clean under the buttocks. And I like to envision a silk leopard print here, okay? So we got that in place. We're going to decrease touching of the vaginal area. And as the head crowns, we tear the amniotic sac if it hasn't already torn. But see, Bo had an amniotic hook on his keychain, so he's already taken care of that, okay? Now, he's telling her to pant or blow to decrease the urge to push, because Bo knows you should never, ever, ever push until you're completely dilated. Well, he's done a vaginal exam and she's complete. We're ready to go. Now, we place the hand on the head, fetal head, and apply gentle pressure. Did I say push it back in till tomorrow? No. I did not say do that. I said apply gentle pressure because we do not want the head to pop out. You don't want the head to pop out. Trauma, trauma, trauma. You ease it out, okay? A lot of times the nurse has to hold it there until the doctor can even get there, right? Right. Well, when the baby's head is out, feel for the cord around the neck and start to clean the baby's face off with a cloth, okay? Now, easy shoulder out. Bo knows not to pull on the baby, okay? And you never pull on the umbilical cord if I forget to say that later. And Hope does not need to push in between contractions. She only needs to push during contractions. The rest will deliver fast. Keep the baby's head down. And I want you to put a big star by dry the baby, because you know that a newborn baby cannot regulate their body temperature, right? We're going to keep the baby at the level of the uterus so that the baby does not get a bolus of blood from the placenta. That's bad. We don't want the baby to get a bolus of blood from the placenta, because that bolus of blood could lead to increased bilirubin levels later. The best place for the baby is on the mother's abdomen, and cover the baby. You see, skin-to-skin contact with mom is the best way to keep the baby warm, okay? Now, y'all, on the soap operas, do they ever keep the baby at the level of the uterus? No, they don't keep it at the level of the uterus. They swing it around. They swing it up here to this camera. And then they swing it up here to this camera. Look at it. Big fat baby, isn't it? It's pretty. It's smiling. It's got a bow in its hair. It's got a tooth coming in. It didn't look like your baby, now did it? No. All right. So they're swinging it around. But the deal with this is this. If they do that too high or too low, then the baby can get a bolus of blood from the placenta. Now then, we need to wait for the placenta to separate. They can push to deliver the placenta, or Bo can massage Hope's abdomen to stimulate the uterus to contract to expel the placenta. When we get the placenta, we inspect it for intactness. Now, y'all, do they ever have the placenta on the soap operas? No, they never have it. It's always retained. It is always retained. Now, when you have a retained placenta, or for that matter, any retained products of conception, what's the number one thing you're worried about? Hemorrhage again. I hope nobody said infection. Hemorrhage again is what I'm worried about. Okay. Now, you know that we always want the placenta to be out within 30 minutes, don't we? That's the rule. We want it out in 30 minutes. Now, everybody in here knows to double clamp and cut if we're in the hospital. But if we're out in Timbuktu, we just need to tie the cord off with something like a clean shoestring, a narrow strip of cloth, or a thick piece of cloth, no closer than 4 inches to the baby's navel. You need to tie off the cord to prevent continued circulation of the baby's blood to the placenta. It's not going to hurt if the placenta remains attached, okay? Now, one point I want to make is you shouldn't use anything like dental floss because that can cut all the way through the cord. That's why we said a shoestring or something like that. Now, you will need to wrap the placenta in a plastic bag and be sure to take it to the hospital with the baby and mom, okay? They're going to want to check that placenta to make sure it's all intact, okay? Now, if you cannot get medical help immediately, then you will need to be sure and to cut the cord with a heated knife or a fresh razor blade. Those are other options you can go by. Now, the cord's going to bleed briefly, all right? It's just a short period of time. So you'll need to cover the cord end with a piece of cloth. And check the firmness of the uterus. Bo knows if the uterus isn't firm, she's going to do what? Hemorrhage. Here we go again with the hemorrhage. So he's over there doing a fundal massage. Now, some cultures like to do what with the placenta? Eat it. That's right. They like to eat it because it's full of iron and protein. Some cultures like to plant it under a tree. Some cultures like to plant the umbilical cord under a tree for good luck. And then some cultures like to do something with the meconium. No, not eat it. They like to put it on their face, okay? Instant facial. Now, let's look at the normal postpartum. Normal postpartum. Vital signs. Well, the temperature may increase to 100.4 during the first 4 hours. 100.4. The blood pressure will be stable. And the heart rate, 50 to 70 is common for 6 to 10 days. 6 to 10 days. Now, let me tell you a secret. If you ever see tachycardia in a postpartum lady, you think hemorrhage. You think hemorrhage, okay? Now, when somebody becomes pregnant, think about this with me. When somebody's pregnant, what happens to their blood volume? It increases by 50%, doesn't it? Yeah, it's going to increase by 50%. So naturally, while I'm pregnant, my heart rate's got to go up to compensate for all the excess volume. But once you have the baby, you diurese. So now your heart rate can come down. It's not pumping as much fluid as it used to. The breast will be soft for 2 to 3 days, 2 to 3 days, and then the dreaded engorgement will occur. The abdomen will be soft and loose and attractive. And some people get something called diastasis recti. Diastasis recti. Now, ladies are not happy when they have this, okay? Well, this is when your mid-abdominal muscles do what? Separate. Ladies don't like this because they were looking forward to their abdomen looking normal again. And here they have a big dent in the center of their abdomen, all right? Now, when you're reading about how to fix this problem, they always say you must do vigorous exercise, or sometimes it just goes away by itself. But when they're talking about the exercise, they always use the word vigorous. We're not just doing a few crunches for this, okay? But many times it goes away by itself or with the help of a friendly plastic surgeon, okay? Now, this occurs, talking about diastasis recti, during pregnancy, but can be seen and palpated more easily after delivery. After delivery. Now, GI, is hunger common? Yes, hunger is common because the whole time you're in labor, will they let you eat? No, because we never know if you're going to have to go to surgery or not. You're lucky if you get an ice chip, right? Right. Now, the uterus just develops a mind of its own now. Immediately after birth, the fundus is in the midline, about 2 to 3 finger breadths below the umbilicus. A few hours after birth, it rises to the level of the umbilicus or 1 finger breadth above. We want the fundus to be firm, of course. And what is the first thing you do if the fundus is boggy? Massage it until it firms up, okay? Massage it until it firms up. And then you need to check the patient for bladder distension. Then check the patient for bladder distension. Because if their bladder is distended, then the uterus can't contract properly. If the bladder's distended, the uterus cannot contract properly. Fundal height will descend 1 finger breadth per day. And what is the proper term for when the fundus descends and the uterus returns to its pre-pregnancy size? It starts with an I. Involution. Involution. Now, if your uterus is not involuting properly, what are you worried about? Hemorrhage. Hemorrhage again. Okay, y'all. How many times have we said hemorrhage with this person? A whole bunch. So if you ever get an OB question and you don't know the answer, what should you pick? Hemorrhage. That's right. Now then, in the little box, we have listed for you some drugs that might be used to control bleeding. Okay? And after pains are common for the first 2 to 3 days and will continue to be common if the mother chooses to do what? Breastfeed. Breastfeed. Because every time she nurses the baby, what is she going to get a surge of? Oxytocin, which forces the uterus to do what? Contract. Makes your uterus contract. Okay. Now we're going to check out the lochia. Here we go. Rubra. 3 to 4 days, dark red. 3 to 4 days, dark red. Serosa, 4 to 10 days, 4 to 10 days, and it's pinkish brown. 4 to 10 days, and it is pinkish brown. Alba, 10 to 28 days, whitish yellow. Whitish yellow. Now, you can have alba up to 6 weeks, okay? Now, I said the color of the alba is whitish yellow, but since I'm a new nurse, I would rather it be more white than yellow, right? If I had to pick. And remember, I said you could have alba up to 6 weeks. And clots are okay as long as they're no larger than a what? Now, usually I hear lots of different answers here. Lots of money, quarter, nickel, dime, 50-cent piece. What do you think the answer is? Nickel. We're going to worry about nickels here, okay? We're not going to wait until they pass a huge clot before we worry. Now, here's the deal. When you did clinical, you saw ladies that passed big clots after they had the baby, and nobody's worried about hemorrhage. Well, those people already have their license, don't they? Yes. The NCLEX people want us to worry early, and when we see a nickel clot, they want us to assume the worst and go get a more experienced nurse just to make sure that the patient's not hemorrhaging, okay? So we're going to worry about nickels here. Now, if somebody who's an experienced labor and delivery nurse looked at that and said, and you told them, I'm going to worry about nickels, what are they going to say about you? That you're a freak, right? That you're a freak because they don't worry about nickels, but we are. You're an output. They're going to diurese for the first 24 hours. Diurese for the first 24 hours. Got to get rid of that fluid, right? Right. And why are we inspecting the legs so closely? DVT. We're worried about a DVT here. All right, moving on to another one of your favorite subjects, perineal care. Perinatal care. Now, they need intermittent ice packs for the first 6 to 12 hours to decrease edema. Warm water rinses, sitz baths 2 to 4 times a day, and anesthetic sprays. Now, these are only indicated if your patient has had an episiotomy, a laceration, or has hemorrhoids, okay? Change the pads frequently. Now, here's the peri-pad rule you've all come for. Are you ready? We do not want them to saturate more than 1 peri-pad per hour. We do not want them to saturate more than 1 peri-pad per hour. Anything more than that, we're going to have to assume hemorrhage. Now, every time I think of a peri-pad, I can't help but think of this. Have you ever been told that the computer at the testing center is looking for your weakness? Well, the computer can't do that. The computer can't look for your weakness. The computer doesn't have a soul. The computer's not psychic. It can't look at you and decide what you're weak in, all right? If that were true, think about all the guys that are going to be taking this test. They would sit down at their computer, and the computer would look at them and say, look at him. He hadn't ever checked a peri-pad. Give him all peri-pad questions. No, it doesn't work like that. See, the computer, if you think like that, you know, in clinical, we know that the guys all got their friend to check the peri-pads usually, right? Right. The computer can't do that. In fact, the computer is looking for something that you're good in. But here's the deal. People always think they get more of what they're weak in on the test. If your friend gets one question on crutch walking, and they don't know anything about crutch walking at all, they missed that day at school, they're going to come to you and they are going to tell you that they got 15 questions on crutch walking, because it is just a rule that people always feel like they got more of what they're weak in. All right? That's just the way it is. All right. We need to teach the patient to report any foul smell and any lochia changes. All right. Now, you know, when ladies have babies these days, they're sent home pretty quickly, aren't they? Yes, they're sent home. So you really got to teach them about the lochia thing, all right, to watch the lochia. Now, let's pretend that you're working at an OBGYN clinic and a patient calls you and says, look, I've made it up to Alba, but now today I went back to Rubra. Do you tell that patient to rest more and stay off their feet, or do you tell them to call 911? Hey, you're thinking inclexy if you said call 911, okay? Because we, as new nurses, have to assume they are what? Hemorrhaging. Breast care. Cleanse with warm water after each feeding. Let air dry. And I don't have anything on here about soap. Why? Because soap is too drying. Soap is too drying. A support bra will be needed. Ointments for soreness can be used, or the mom can express colostrum and let the colostrum dry on the breast, and that will also help. Breast pads need to be used to absorb moisture after the milk comes in. You never want moisture against the breast, because then that can cause skin breakdown. They need to initiate breastfeeding as soon as possible after birth. Well, first of all, this is a bonding thing. But also, what does it help your uterus to do? Contract. It helps the uterus contract and control bleeding. Now, if breastfeeding has to be interrupted, in other words, the mother will have to be away from the baby, what will she want to do? Use a breast pump. She will want to use a breast pump, okay? And now they've got the professional breast pump in the pretty briefcase, so nobody knows what you've got in your little briefcase, right? Right. Now, increase calories by 500. Increase calories by 500. Fluid and milk intake is important. Now, here's the rule of thumb. 8 to 10 8-ounce glasses of fluid a day. 8 to 10 8-ounce glasses of fluid a day. If you're a breastfeeding mother, you need to drink plenty of fluids, because if you don't, you could get what is called a plugged duct. A plugged duct, and then you're getting closer to getting mastitis, and we certainly don't want our patient to get that. Now, you can also get plugged ducts if the baby is not breastfeeding well, all right? So fluid is very important. Now, non-breastfeeding mothers. Well, about the only thing we can hope to do is decrease engorgement. Decrease engorgement, right? That's what we're trying to do is decrease engorgement so that you get them to use ice packs, breast binders, or chilled cabbage leaves. Now, I know that sounds weird, but chilled cabbage leaves will help decrease engorgement, and if the patient's starting to have any inflammation, that will decrease inflammation too. And all they do is keep the cabbage in the refrigerator, and they peel off sheets of it and stuff it into the patient's bra, okay? And that decreases engorgement and inflammation. Another thing is this about decreasing engorgement. You need to tell the person when they take a shower to not let the water hit their breast because that heat is going to make the engorgement worse. All right? Only let the water hit their back. Also, no stimulation of the breast at all because that's going to make the mother make more milk. So no stimulation of the breast at all. And if your hospital does not use breast binders, or if the patient doesn't want to pay for one, they can just use a ACE wrap and wrap all the way around the chest, an ACE wrap. Now, postpartum infection is an infection within 10 days after birth. The major bacteria are E. coli, and you know where that lives, don't you? And beta hemolytic strep, which we're going to talk a little bit about a little bit later, okay? Now, some people are just carriers of strep, aren't they? Well, what do we do for this postpartum infection? We teach proper hygiene, like front to back cleansing, and I can't emphasize teaching that enough. I do not care how educated somebody is, how refined somebody is, how old they are. You teach it, teach it, teach it, okay? And also hand washing, we can't teach that enough. And the patient usually is going to have cultures and antibiotics. Cultures and antibiotics. Now, postpartum hemorrhage. Early is when more than 500 cc's of blood is lost in the first 24 hours. Late is after 24 hours and up to 6 weeks postpartum. Causes, well, uterine atony. Well, that's when your uterus does not have any tone. No tone. It's not contracting. And if you don't have tone, if the patient's uterus is not contracting, what are they going to do? Bleed. That's what we don't want to happen, okay? Now, other causes of postpartum hemorrhage are lacerations, retained fragments, and forceps deliveries. As you know, forceps delivery can be very traumatic. That's why we just don't see a whole lot of them anymore, or one of the reasons we don't. All right, the next problem that we have, mastitis. Major bacteria, Staphylococcus, and it usually occurs around 2 to 4 weeks. Now let's talk about how people get it. You can get it from poor hygiene, for one thing. Poor hygiene. But probably the main reason people get it is because they aren't breastfeeding properly. Maybe they have not been taught proper breastfeeding. And they're not emptying the breast with each feeding. They're not emptying the breast with each feeding. That is very important. See, if you're not emptying the breast with each feeding, then you can get stagnation of milk, which leads to inflammation of the breast tissue. We don't want stagnation. Now remember, the milk is okay. It's you that's messed up, right? Yes, the milk is okay. The only reason the milk would not be okay is if the patient were taking a drug that passed through the breast milk. Other than that, the milk's fine, and we're going to talk more about that. Now, treatment, bed rest. Of course, they're going to want to wear a support bra because are they going to be engorged? Yes, they're going to be engorged. There's binding and chilled cabbage leaves again. Remember, we're trying to relieve engorgement, all right? Now, binding the breast and the use of cabbage leaves to relieve engorgement is only used if breastfeeding is being discontinued permanently. Underline the word permanently there. If mom is going to continue to breastfeed, she needs to initiate breastfeeding frequently or pump. Now that's important. The mother will heal more quickly if she empties the affected breast as many times as she can. That is why we say that she needs to use the breast pump or feed the baby frequently, because the more they empty the breast, the sooner they're going to get well. In fact, if they don't empty the breast repeatedly, the problem's just going to go on and on and on. That's very important for helping the patient get well. You have to be careful with binding, though, because when you're binding the breast, that can actually cause more stagnation, okay? Penicillin is the drug of choice, and penicillin is fine to use with breastfeeding. Now, let me ask you something. What if you have a breastfeeding mother who is on a medication like an antibiotic? When should they take the antibiotic in relation to the feeding? Well, what you do is they need to feed the baby, then take the antibiotic right after they feed the baby. They need to feed the baby first and then immediately take the antibiotic after. So you're trying to make sure the baby gets the smallest amount of antibiotic in their system. We don't want the baby to get it, okay? And pain medicine, maybe. It depends on if you're still breastfeeding or not. Now, heat is the next thing on your handout. Get in a hot shower is one thing that they may say, okay? Because this will help the breast to leak. That heat will help the breast to leak and will help relieve the pressure and soften the breast, okay? Relieve the pressure and soften the breast. And last, again, we say feed the baby frequently. Now, we're really emphasizing this. Now, you tell somebody with mastitis to feed the baby frequently, and what are they going to say? It hurts. It's a very, very uncomfortable thing, okay? So, but it's important because if they don't empty the breast repeatedly, they're not going to get better, okay? Now, another thing, if you're nursing the baby and you have mastitis, you always offer the affected breast first. You always offer the affected breast first. Now, think about that. When you start feeding the baby's hungry, right? Yeah. So you offer the affected breast first because that's the breast you want to make sure gets emptied every time. Normally with breastfeeding, if you have somebody that does not have mastitis, you alternate which breast you start with, okay? You alternate which breast you start with. Like if you got somebody who's feeding the baby every 2 hours, 8 a.m., you start with the left breast. The baby's hungry, they're going to empty that breast, and you swap them over to the right. Well, the baby's not going to empty the right breast because they're already getting too full. So when they feed the baby at 10 a.m., they need to start with the right breast and make sure it gets emptied out. All right, immediate newborn care. Well, suction, first of all. Clamp and cut the cord, maintain the body temp, and they're going to do an Apgar. And that's going to be done at 1 and 5 minutes. 1 and 5 minutes. And it looks at heart rate, respiration, muscle tone, reflex irritability, and color. And we want at least 8 to 10. We want at least 8 to 10. Most babies get a 9. Most babies get a 9. Why? Purple hands and feet. Purple hands and feet, also known as acrocyanosis. Acrocyanosis. Now, erythromycin, drops or ointments for eye prophylaxis for Neisseria gonococcus, okay? And erythromycin will also kill the most rapidly growing STD in the country, which is chlamydia. Chlamydia. It will kill chlamydia. Okay. What is aquamaphytin? Vitamin K. Vitamin K. It promotes formation of clotting factors. It promotes formation of clotting factors because you know the baby's not going to have their own clotting factors until they've been eating for a week, right? Right. Now, it's an IM. Since it's an IM, into what muscle are you going to give it? Vastus lateralis. The vastus lateralis. All right, now cord care. Cord care. Well, it's going to dry and fall off in 10 to 14 days. Cleanse with each diaper change using alcohol because alcohol is very drying. Now, some hospitals are just using normal saline, but alcohol is a pretty standard thing here. We fold the diaper below the cord and no immersion until it falls off. In other words, you don't let the cord go under the water. Because if you've got somebody who's immersing their baby's cord underwater before it falls off, then it's going to stay wet and moist and harbor bacteria, and there they're going to be 18 years old down on the beach one day with their cord, right? And an infection. That's not good. Now, why do babies sometimes experience hypoglycemia after birth? Because they're not getting glucose from whom? The mother. They're not getting glucose from the mother. Babies at greatest risk for hypoglycemia include those that are large for gestational age, small for gestational age, preterm, and babies of diabetic moms. And normally you just give them a bottle of sugar water, don't you? Pathologic jaundice occurs the first 24 hours, and usually it means an RH or an ABO incompatibility. Physiologic jaundice occurs after 24 hours, and it's due to normal hemolysis of excess red blood cells releasing bilirubin. Now, we have one more thing I want to talk about before we get into our complications of pregnancy. RH sensitization or RH factor. Now, y'all, there are books this fat written on this subject. We don't want to read those books now, do we? Not right now. Not for NCLEX. Let's just understand this. And the first thing you've got to do is put a star by the first sentence, because if you don't get that, you'll never get it. It occurs when you have an RH negative mother with an RH positive baby. Negative mom, positive baby. That's the only time this is a problem. Now, anytime RH positive blood from the baby comes in contact with mom's RH negative blood, the mother treats it like a foreign body, an antigen, because isn't it different from her blood? Yeah. Anytime a foreign body gets in your body, what do you make? Antibodies. So that is what mom's body is doing. It makes antibodies to the baby's RH positive blood. Mom's blood is most likely to come in contact with baby's blood when the placenta separates at birth. But it can also happen during a miscarriage, amniocentesis, or when there is trauma to the mom's abdomen, right? Yes. Now, the first offspring is not affected by the antibodies, because if I have my baby today and our blood came in contact with each other, do I have the antibodies today? No, it takes a while to get those antibodies in the system, so that's why the first offspring is not affected. The chances of an RH negative mom having antibodies to RH positive blood increases with each pregnancy and each exposure to RH positive blood, because once you have these antibodies, they never go away. So we want to prevent the antibodies from ever forming. Now, let's pretend that an RH negative mom, sensitized, that means they've already got the antibodies, gets pregnant again. Well, she's got these antibodies waiting for RH positive blood to come around so she can attack it, right? Yeah, because she's sensitized. Okay? The mother's blood enters the baby through the placenta, so hemolysis occurs, and all the baby's RBCs are breaking down. So that leads to bad things like hyperbilirubinemia, anemia, hydrops fatalis, which is severe hemolytic disease, CHF, and neurologic damage. And all of those things together are known as erythroblastosis fetalis, okay? Now, when you start having breakdown of RBCs, is the baby going to keep on growing? No, it's not going to keep on growing, because think about it. If they're breaking down red blood cells, are they anemic? Yes. Are they hypoxic? Yes. And babies and children that are hypoxic and anemic do not grow correctly. So at some point, they're going to stop growing. That's one of the things we're watching for. Now, the indirect Coombs is done on the mother, and it measures the number of antibodies in the blood. The direct Coombs is done on the baby. That's what we do on the cord blood, okay? The cord blood. And it tells you if there are any antibodies stuck to the RBCs. Now, what do you do if you wind up with an Rh-positive fetus and a sensitized mother? Now, I'm going to tell you the simplest things because there's a lot of really high-tech procedures they can do. The simplest thing to do is this. Frequent ultrasounds. Frequent ultrasounds. Watching the baby's growth. Frequent ultrasounds. Watching the baby's growth. And when the baby stops growing, that's when they take the baby. When the baby stops growing, early birth. Early birth. All right. Now, when is RhoGAM given? Within 72 hours after birth. Within 72 hours after birth. Now, some doctors give the patient a 28-week dose too. A 28-week dose. Well, if you get the 28-week dose, you're still going to get the within 72-hour dose as well, okay? You get both. Now, let's look at how RhoGAM works. It destroys fetal cells that got into the mother's blood, and it has to do this before antibodies can be formed. Because if antibodies are formed, then RhoGAM doesn't do you a whole lot of good, right? Because they've already got the antibodies. Now, here's the deal. Let's say that I am an Rh negative mom, and I'm 4 months pregnant, and I decide to have an abortion. Is there a chance that there is bleeding with that? Of course you're going to bleed. So what will they go ahead and give me? RhoGAM. What if I'm having an amniocentesis? Is there a chance of bleeding? Yeah. So what, and I'm Rh negative. What will they go ahead and give me? RhoGAM. What if I'm in a bad car wreck? Is there a chance that that my blood came in contact with baby blood? Yeah. So what do they go ahead and give me? RhoGAM. The standard rule of thumb is this. You give RhoGAM with any bleeding episode. Any bleeding episode. All right. Now, before we get into the complications of pregnancy, I want you to take a break.